Jetto, everyone, settle down. So today we are going to tackle a very, very important chapter in pharmacology, the drugs for mental illness. And I'm telling you, this knowledge, you will be using it every single day in your practice. And of course, it's a huge favorite for the examiners. So pay close attention, huh? Let's jump right in.
So let's begin with a really fundamental question. We prescribe these medicines all the time, right? But what is actually happening inside the brain? I mean, think about it. How can one small tablet change something as complex as a person's mood? That's the big puzzle we're going to piece together today.
Okay, so here's our game plan for today. First, we'll see how these antidepressants work. Then we'll compare the old drugs versus the new ones. After that, we'll look at the serious side effects and dangers. Then we'll see their other uses beyond depression, and finally, we'll touch upon drugs for anxiety. Simple enough? Let's get started.
Right then, our first section. Look, before we can even think about treating something, we have to understand what's going wrong, right? The why of it. So let's dive into the brain's chemical story.
So, this is the classic theory, the one you have all mugged up from your textbooks, I'm sure, the monoaminergic hypothesis. What does it say? Basically, that depression is just a chemical imbalance, a simple shortage of neurotransmitters like serotonin and noradrenaline. Sounds pretty straightforward, no? But hold on, the story is actually much more fascinating than that.
Now, this is where things get really interesting. This is the more modern view, the neurotrophic hypothesis. It says, hey, it's not just about the level of chemicals, it's about the health and the structure of the brain cells themselves. It connects depression with low levels of a protein called BDNF. Now, think of BDNF as like fertilizer for your brain cells, for your neurons. And if you don't have enough of this fertilizer, your neurons start to shrink and you actually lose connections. It's a physical change.
And here, this is the most important part. The two theories are not separate, they are linked. You see, the antidepressant drugs give that immediate chemical boost to the monoamines, right? But that's just step one. That initial boost over several weeks signals the brain to start producing more BDNF. And it's this BDNF that then starts repairing the brain, growing new connections, new synapses. This explains perfectly why antidepressants take 2, 3, even 4 weeks to show an effect. The real magic isn't the quick chemical fix, it's the slow structural repair that follows. It's brilliant, isn't it?
Okay, so now that we understand the theory a bit better, let's look at the actual drugs. Let's see how our toolkit as doctors has changed, how it has evolved over the decades.
First up, we have the old guard, the original players, the tricyclic antidepressants, or TCAs. Now, these were the absolute pioneers in this field. And don't think they are just history. You will still see them being used, especially for really tough, treatment-resistant cases. So you absolutely have to know them inside out.
But these old drugs came with a very heavy price. Just look at these limitations. They are absolutely key. They caused all sorts of anticholinergic side effects. Dry mouth, constipation, you name it. They carried serious cardiovascular risks. And the biggest problem, the most critical one, they were extremely dangerous in an overdose. Now think about that for a second. You are giving a potentially lethal drug to a patient who might be suicidal. That's a huge, huge problem.
So, naturally, because of all these problems, the search was on for something better, and that led to a new wave of drugs, the selective serotonin reuptake inhibitors, the SSRIs. And I'm not exaggerating when I say these drugs completely revolutionized the treatment of depression. Why? Because their safety and their tolerability was just so much better.
This slide, it just lays it all out, crystal clear. Look, on one side you have the TCAs like amitriptyline, heavy sedation, strong anticholinergic effects, high cardiac risk. Very, very dangerous if the patient takes too many. And on the other side, the SSRIs like fluoxetine. Little or no sedation, no anticholinergic problems, minimal cardiac risk, and so much safer in an overdose. Guys, this is a classic Viva question. The examiner will definitely ask you to compare a TCA and an SSRI. Make sure you know.
And this table just summarizes that trend beautifully. You can see it clearly, right? As we move from the old TCAs to the SSRIs and then to the SNRIs, look at the columns for sedation, antimuscarinic effects, cardiac risk. They just go down, down, down. The whole goal of drug development here was simple. Keep the benefit, but drastically improve the safety.
All right, now for the part that every single one of you as future doctors must master: the risks. Think of this next section as the user manual for these drugs. Let's talk about side effects and dangers.
This is a very serious statement, a grim clinical reality. Poisoning with TCAs is frequent, usually self-attempted for suicide, and may endanger life.
a TCA overdose is not a small thing. It is a full-blown medical emergency. The very medication you give to help someone can become the instrument of their death. That's why understanding this is so critical.
So imagine this. You're on duty in the emergency room and a patient comes in with a TCA overdose. What do? First things first, supportive care is everything. Gastric lavage if they're early, secure their airway. Then, you have to correct the acidosis with bicarbonate. This is very important. Control the convulsions with IV diazepam. And then you have to treat the deadly arrhythmias, often with something like propranolol or lidocaine. And please remember this, some common antiarrhythmics are contraindicated here. They can make the situation much worse.
Okay, so we've established SSRIs are much safer, but that doesn't mean they're perfect. They have their own set of side effects, and you need to counsel your patients about these. Nausea and GI issues are very common at the start. Sexual dysfunction is a big one, and you have to ask about it directly because patients are often too shy to bring it up. And you must always keep the risk of serotonin syndrome in the back of your mind, especially if you're combining drugs. It's rare, but it can be fatal.
Right. Let's widen our view a little bit. It's really important to understand that these drugs are not just antidepressants. That's just one of their jobs. They are incredibly versatile medicines that we use for a whole bunch of other conditions. I mean, just look at this list. We use them for obsessive-compulsive disorder, for panic disorder, for social phobia. We use them to treat neuropathic pain, like in diabetic patients, even for conditions like premature ejaculation or to help people stop smoking with bupropion. It just goes to show you how these neurotransmitter systems, they're involved in so many different functions in our body and brain.
Okay, and for our last section today, let's talk about a topic that goes hand in hand with depression and one you will see all the time, anxiety. We're going to take a quick look at the drugs we use to treat it, the anxiolytics.
So this picture here gives you a nice, simple classification. You can see the main groups of drugs we use to fight anxiety. The most famous ones, of course, are the benzodiazepines, but we also have other classes, and sometimes we even use things like beta blockers. Now, the most important class by far is this one, the benzodiazepines, or BZDs. I'm talking about drugs like diazepam, lorazepam, alprazolam. I mean, these are some of the most prescribed drugs on the planet. And how do they work? They basically boost the action of GABA, which you'll remember is the main inhibitory neurotransmitter in the brain. It's the brain's primary off switch, the main calming signal. So the big question is, why did these drugs become so incredibly popular? Well, it's pretty simple. They work. And they work fast. For quick anxiety relief, they are highly effective. They were also much safer in overdose compared to the older drugs like barbiturates. Plus, they have anticonvulsant properties. So for a very long time, they were the absolute kings for treating anxiety.
But, and this is a huge but that you must never, ever forget, there is a major catch. The biggest problem with these benzodiazepines is the potential for dependence and cognitive impairment with long-term use. This is the single biggest reason their use is now limited, especially for chronic anxiety. This is why for long-term treatment of anxiety disorders, we now often prefer to use SSRI.
So, to finish up, I want to leave you with a question to think about for next time. We have spent all this time talking about how the new drugs, the SSRIs, are so much better and safer. So why do we still keep the old TCAs around? Are they just museum pieces, or are there still some very specific situations, some specific patients, where an old TCA might actually be the best choice? Have a think about that, and we'll discuss it in our next class. Thank you.
Namaste, future doctors, and welcome to our class. Today, we're going to be diving into something you will see every single day on the wards. I'm talking about anxiety and pain. So please, get your minds ready because this is knowledge that is absolutely going to save lives.
All right, chalo, let's get started. I know, you're all very eager to get to the wards. But trust me, what you learn in this lecture hall, this is what will make you a truly great doctor. So let's build that foundation together, shall we?
So picture this. Every single day in the ward, you're going to be faced with two major challenges, anxiety and pain. You'll have a patient's mind just racing with worry, and at the same time, their body is crying out for relief. Your job is to know the right tools to manage both. So let's start by looking at anxiety.
Okay, first up, let's talk about anxiety. And let me be very clear here. This is not a one-size-fits-all problem. I mean, you wouldn't use a defibrillator on a patient with just a common cold, would you? Of course not. The very same principle applies here. You have to choose the right tool for the right situation.
So imagine a patient comes to you.
They're in the middle of a full-blown panic attack. Their heart is pounding, they're struggling to breathe. This is an emergency situation. What is the first drug that comes to your mind? What do you reach for?
Well, this slide makes it simple. For a panic attack, an acute crisis, you need a firefighter. That's your benzodiazepines. They act fast, they're urgent, they put out the immediate fire. But for long-term chronic anxiety, you need an architect. You need someone to build a long-term strategy. Drugs like buspirone or SSRIs, they take a few weeks to work, but they build a solid foundation of calm. See the difference? One is for the emergency, the other is for the long-term plan.
And speaking of architects, let's look at buspirone. Now, this is a very unique tool in your kit. It's not a benzodiazepine, which means, and this is important, no major sedation and critically, no risk of addiction. But here's the catch, it's slow. Its effect is delayed. It works on the serotonin system, fine-tuning things, and that process just takes time. So what does that mean? It means you never, ever use it for an acute panic attack. This one is strictly for long-term management.
All right, so we've covered the worried mind. Now let's turn our attention to the body in pain. And to do that, we absolutely have to talk about the king of pain relief, morphine. This is the prototype, the original opioid analgesic, the one by which all others are measured.
And where does this incredibly powerful molecule come from? Well, it comes from nature, from this plant, the opium poppy. From this beautiful flower, we get one of the most effective pain relievers known to medicine. It's been used for centuries, and it is our responsibility to learn how to use it wisely.
Now let's be very precise about our terms. What do we actually mean by analgesic? It's a drug that specifically, selectively relieves pain without knocking the patient out, without significantly altering their consciousness. You can think of it as a targeted strike against pain, not a full-on assault on the central nervous system.
Now this is what makes morphine so special. It has this remarkable dual action. First, yes, it blocks the pain signal from reaching the brain. But second, and just as important, it changes the brain's emotional response to that signal. The pain might technically still be there, but the patient is no longer distressed by it. They can tolerate it. This dual action is what makes it so incredibly powerful.
But, with great power comes great responsibility. Morphine is an extremely powerful tool, and to use it safely, you must understand its risks. So, let's open up the safety manual and look at the dangerous side of this drug.
You see, morphine's effect on the central nervous system is, well, it's a bit of a paradox. It's a game of push and pull. It slows some functions down, it depresses them, while at the same time it speeds other functions up, it stimulates them. And it is absolutely crucial that you know the difference.
So what does morphine slow down? What dials does it turn down? Well, it provides analgesia, pain relief. It causes sedation, so patients might feel drowsy. It suppresses the cough reflex. But the most important one, the one I want you to remember above all others, is this. It slows down breathing. This respiratory depression is its most dangerous and potentially lethal side effect.
And what does it speed up or stimulate? Well, it can trigger nausea and vomiting by stimulating what we call the chemoreceptor trigger zone. Think of it as the brain's vomit button. It also causes the pupils to constrict, giving us that classic sign of pinpoint pupils that you hear about with opioid use. And it can stimulate the vagal center, which actually slows the heart rate, a condition we call bradycardia.
Please remember this. The line between a therapeutic dose and a toxic one, it can be very, very thin. For a vulnerable patient, maybe someone elderly or with a lung condition, a single dose can be enough to cause respiratory failure. That is the reality, the gravity of working with this drug.
Now, something interesting happens with morphine. Patients can develop a tolerance to some of its side effects, like the sedation or the nausea. But there is one side effect they never develop a tolerance to: its effect on the gut. Constipation is a persistent, chronic problem for any patient on long-term morphine, and it's something you will have to actively manage.
So, we're nearing the end of our lecture. But for you, this is all just the beginning. The prescription pad that you will one day hold, it is an incredibly powerful tool. It has the power to relieve immense suffering, but it also has the potential to cause great harm. And that is a responsibility you must take very, very seriously.
So, what are the key takeaways from today? For anxiety, always remember the difference between the firefighter and the architect. Match the drug's speed to the patient's need. For pain, remember that morphine changes the entire experience, not just the sensation. And always, always be mindful of the risk of dose-dependent respiratory depression. Your job as a doctor is to balance the profound relief these drugs can offer against their profound risks. You see,
Knowing the pharmacology of these drugs, the receptors, the side effects, that is the science of medicine. But understanding your patient, their fears, their life, their unique physiology, that is the art. And every day you will need to combine that science and that art to make the right choice. So I'll leave you with this question to ponder. Where will you draw that line? Class dismissed.